So, welcome, my dear friends. Myself, Professor Dr. Rajendra Deshpande, and as you know that I am MD in Ayurvedic medicine and MD in Ayurvedic physiology. For paid online consultation, you can definitely WhatsApp on 922-681-0630. My dear friends, today this is an interesting topic related with our medical general practice, that is oral hypoglycemic drugs. There are different names, title will be different. For example, oral hypoglycemic agents. So when you say agents, it is called as OHA. So many times in the exams of the BMS, MBBS, homeopathy, this is, and even pharmacology, this question is very common in the internal medicine, and this type of information is not only the students must remember for theory, but better they can understand this topic as the part of their successful medical practice, because they must treat the many patients of diabetes. So the word is very simple. Oral is oral. That means, as you know, that diabetes is a disease of metabolism, and it is a problem with the carbohydrate metabolism. We have the 6 proximal principles of food. You may be remembering: proteins, carbohydrates, fats, vitamins, minerals, and water. And in this, all these elements should be digested, should be metabolized in our body. Then only they are helpful for our body. So amongst these, there are three important: proteins, carbohydrates, and fats. So carbohydrate means, the simple examples are the chapati that we eat, that is a wheat. Then what is the rice that we are taking? So wheat, rice, potato, direct sugar. These are all the examples, or the even any sweets. These all the things contain a lot of carbohydrates, and the main function of carbohydrate is to provide energy to the body. Try to understand whatever we are having. Now I am taking the lectures and I am speaking very loudly and energetically. From where I am getting this energy? I am getting this energy from carbohydrates. So carbohydrate is an instant source of energy, but there is also a source which is called as a stored energy, and that is coming through the fat. Fat means ghee and the oil. And the last is a protein. Protein is basically from the pulses, and or the non-veg food, or the eggs, chicken. So these proteins molecules are very essential to take care of wear and tear of the body. We want to regenerate the cells. We want to make the growth of our body. That all together is depend on the protein consumption. Now, diabetes is a problem of carbohydrate metabolism, and there is a deficiency of insulin. Insulin is the name of the hormone. Insulin is secreted by beta cells of Langerhans. Insulin is secreted by pancreas, and this insulin is, when it is a deficient, that is called as a diabetes mellitus. There are mainly two words: diabetes mellitus and diabetes insipidus. Don't get confused. Diabetes mellitus, diabetes mellitus is, uh, just a moment, I have the one. Okay. No, Mr. Ankit, whatever I am discussing is not in the present slide, because slides are basically composed of only discussing about the medicines. But this is a type of introduction I am giving you, general information about the diabetes. Is it okay for you? So you can write it, you can write the message, because this is not in the slide. I'm going to share you this particular whole slide. Okay, right. So we are discussing about basics of diabetes, because unless and until we don't know the basics of diabetes mellitus, then we cannot have the idea of OHA. Okay, so that's why diabetes mellitus is a deficiency of insulin, and diabetes insipidus is a deficiency of ADH, anti-diuretic hormone, which is secreted by posterior pituitary gland. There is no confusion. Diabetes mellitus is related with sugar, but diabetes insipidus is nothing to do with the sugar. Diabetes insipidus is very, very rare in our practice. No patient will come to you for diabetes insipidus. But the common symptom for diabetes mellitus and diabetes insipidus is polyuria, increased frequency of urination and lot of urine. So these are the features for both diabetes mellitus and diabetes insipidus. But when you will examine the urine of both the patient, diabetes mellitus and diabetes insipidus, sugar will be present in diabetes mellitus. Sugar will not present in the urine sample of diabetes insipidus. Try to understand. When the sugar is present in the urine, it is called as a glycosuria. Glycosuria is diabetes mellitus. Glycosuria is not present in diabetes insipidus. There are now not only insulin deficiency. Sometimes what happens? Insulin is okay, amount is okay. But insulin, what is the role of insulin? What insulin is doing? Insulin is hormone which is helping blood sugar to enter into the cell. To enter into the cell, try to understand. And that entry is allowed only with the insulin. If there is no insulin, there will be sugar in the blood, but it cannot enter into the cell, and cell will be craving for sugar. We want sugar. We want sugar. That is about cell. That is about cell. And so cell are getting tired because they don't have the sugar. Sugar is in the blood, but not in the cell. That is because of deficiency of insulin. Now, insulin is helping on the cell wall, but there is also another factor which is called as a insulin receptor that are welcoming insulin. They are allowing to act insulin on the cell membrane. That means sometimes there is a deficiency of insulin, sometimes there is a deficiency of receptors. When we advise the patient to make exercise, what is the role of exercise? It will also stimulate the pancreas, but at the same time, walking is increasing the number of receptors. And that is why insulin can act better. So there are two factors, insulin hormone and insulin receptors. Now, when we talk about the action of these oral hypoglycemic drugs, they are acting on the two levels. Some medicines are stimulating beta cells of Langerhans, which are present in pancreas. So pancreas is having endocrine function as well as exocrine function. Are you getting my point? So these oral hypoglycemic medicines or the drugs are acting to stimulate the pancreas, number one, and some medicines acting peripherally. That means all over the body in the cells, and they are helping to action of insulin on the cell membrane. Receptors are stimulated because of some medicines. Okay, so let us start the particular action of these oral hypoglycemic drugs, which are the name of the drugs. So there are different names, but basically the students must remember only two names, bigunides and sulfonylurea. This is the main classification of diabetic medicines. Diabetes mellitus. Bigunides, sulfonylurea. Bigunides, sulfonylurea. And all the remaining things are a part of these bigunides and sulfonylurea. So only two names are important types, bigunides, sulfonylurea. Now in the next lecture, we are also seeing which are coming under bigonide, which are coming under sulfonylurea. But in this lecture, I have made the separate list. For example, next is a dipeptidyl peptidase 4. Here the name, short form, DPP4 inhibitors. Inhibition means to stop something activity. Stopping the activity is inhibitor, and another is a stimulator. So what they are stopping, I will explain afterwards. So this is, you can remember DPP4 inhibitors. DPP4 inhibitors, just as for only for examination. In the second lecture, I am going to most talk about practical importance, or how we can think about practice. But here, these all the things you have to return short forms. Don't remember this whole name. That is of no use. Here only ASE means this is something enzyme. It is acting on the enzyme and it is stopping the enzyme activity, that is inhibitors. DPP4 inhibitors. The market, the name, the drug available is gliptines. Gliptines. Everywhere there is a G, G, G. G for glucose. G for glucose. Many names, pharmacological names of the medicines: gliptines, glioflozins, glitazones, glinides, glucobe, okay, and ribelus. Some names are different, but most of the names are G. I know this slide is something looking difficult, but don't worry. Afterwards, I am going to tell you very simple examples. So don't take the stress of this slide. Okay. So only in this slide you remember bigonide, sulfonylurea. Next medicine is DPP4 inhibitors. Then there is a SGLT2. SGLT2 inhibitors. Second is also inhibitor medicine. First is DPP4 inhibitor. Second is SGLT2 inhibitors. You will try to remember these names. Huh? Don't go for these long names. No, nothing. Not necessary. Not necessary. Even in the practice, not necessary. And nobody will ask you. But DPP4, yes, you must remember. DPP4 inhibitors. That is the gliptines. SGLT2 inhibitors. That is gliflozins. Sorry, gliflozins. 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 Now, in spite of this thiazolidinones, I will say you remember glitazones. You remember only glitazones. Glitazones. This name is not important. Then here, meglitinides. This also you remember. Meglitinides, there are, this, I'm sorry, this is unnecessary duplication. This is a printing mistake. That is glinides. You remember the glinides. Glinide word is very popular in the doctors. Glinide. Which medicine I am using? That is the gliptines. Then glioflozins. This is uncommon. Then glitazone is very common. Glinides is very common. Okay. Then next is acarbose. Forget about this previous one. This is also inhibitor. Acarbose, glucobe. Acarbose, glucobe. Acarbose, glucobe. You see my video all the time, and how the Deshpande sir is mugging up. This will be important for your remembering the thing. Acarbose, glucobe. Okay. Next is a GLP-1 receptor agonist. You try to understand. These are the very important words. Agonist is a stimulator having same action, and antagonist is opposite. I repeat, agonist same action, antagonist opposite action. You can make the notes also. Agonist helping to the receptor, antagonist opposite. But here we want that receptor should be stimulated. Insulin receptors are stimulated by GLP-1. GLP-1. That is semaglutide. 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 And what is that? Ribelsus. Ribelsus. Uncommon. Ribelsus. Don't remember the previous long names. Never. So actually in this slide there are 8 type of the oral hypoglycemic agents. In this slide, my dear friends, try to remember only these basic 2 types. Bigonides, sulfonylurea. Bigonides, sulfonylurea. These two groups are very important. Then in this slide, DPP4 inhibitors, that is gliptins. Then SGLT2 inhibitors, that is gliflozins, gliflozins. Next is a glitazone, very common. This is commonly used, glitazones. Write down, glitazone, commonly used, glitazone, commonly used. Next, glinides, commonly used, meglitinides, that is glinides, commonly used. Please write down. Acarbose, commonly used. Acarbose glucobay, commonly used. Acarbose glucobay, commonly used. Acarbose glucobay, commonly used. Next, GLP-1 receptor agonist. Receptor, that means they are helping to the insulin receptors, and naturally blood sugar will enter from blood to the cell. The type is GLP-1 receptor agonist is semaglutide, ribelsus. Relax, we will go further. Now, mechanism of action. First is a bigonide. The famous medicine is glycomet. Very commonly used in the practice. If you are going to visit to any doctor for the observer in any clinic, any hospital, you will see many patients are taking glycomet. Glycomet is a type of bigonide. Glycomet. What they are doing? Try to understand. Mechanism of action. Primarily, this bigonide glycomet tablet reduce hepatic glucose production. Hepatic, that glucose is stored in the liver. Whenever excess blood sugar is there, it is stored in the liver, and that is the form glycogen. And whenever necessary, glycogen is converted to glucose. Excessive sugar is stored in the liver. That name of the stored glucose, is glycogen. And sometimes that glycogen is again converted to glucose, blood glucose, of course. But that cannot happen because of the bigonides. It is stopping to the liver and say, no, we don't require your help right now. We don't want that liver should convert any type of the material into the sugar. So that production is being reduced by bigonide, glycomet tablet. And number 2, improve the insulin sensitivity in the peripheral tissue. That means they are acting on the receptors. Try to understand. Peripheral tissues means our cells of the body, whole body, from brain to my foot. Everywhere there is a cell. Muscles are having cells. Liver is cell, kidney cells, brain cells, heart cells, intestinal cells. Each and every cell, they have the receptor for insulin. So those receptors are stimulated by bigonides. So bigonide is acting at 2 levels. One is liver, that they are not saying, liver, you should not create any sugar. Stop. And they say to the receptors, get stimulated and allow the insulin to act. Okay, so they improve the insulin sensitivity. Peripheral, this word is very important. Pancreas is a central organ. So some medicines will act on pancreas. Some medicines will act on peripheral tissues. Two things are very clear. OHA, oral hypoglycemic agents. Agents means medicines. In short, these are the diabetic medicines we are discussing. Diabetic medicines are basically 2 types, bigonides and sulfonylurea. Bigonides are acting at periphery. Whole cells, complete cells of the body acting and giving stimulation to the receptors. Sulfonylurea, I will tell you afterwards, they are basically acting on the pancreas. So this is the difference. Okay. So in bigonides, this is a type, pharmacological type, medicine type. But the main generic name of this bigonide is metformin. Very popular. Very popular. Metformin. Bigonide, metformin. Bigonide, metformin. Then, sir, what is that glycomet? Glycomet is a brand name. Glycomet or glucophase. These are the brand names available in the medical shop. If you go to the medical shop, you will ask bigonide, give me bigonide. He will say, no, I don't know what is bigonide. Some pharmacist may know, but basically patient should ask for the glucophase or glycomet. But glycomet name, you must remember. Glycomet, metformin. What is that generic name? Nowadays, there are some shops which are giving generic medicines. There you should write metformin. And what is the doses? For example, it starts 500 milligram once or twice daily with meals, during the lunch, during the dinner. And gradually, for example, one tablet OD, then one tablet BD, one tablet TDS. Gradually, you can increase the dose maximum 2000 to 2500 milligram. But in my practice, I have never given such type of the big dose. I will tell you what to do. In the practice, we have the second lecture in the afternoon. We will discuss, okay? But minimum dose and maximum dose per day, 200 is not one time. We have to give 2 tablets, for example, 2 times in a day, 2 BD. That is 1000 in the morning, 1000 in the evening. Are you getting my point? 2000 means 2 tablets of this glycomet. Extended release formulations allow for once daily dosing. This is extended. That means glycomet, for example, there is a SR. SR means sustained release. Sustained release means SR. Some tablets are available as SR, that is extended release formulation. They slowly release the content. Metformin is slowly divided or break down slowly in the stomach or in the liver, and it is provided to the blood. Okay, so that is extended release formulation. Then naturally only one time is sufficient, because they are slowly, after 2 hours, after 4 hours, they are releasing the metformin in the blood. I think this bigonide glycomet is very clear. Let us move further. Bigonide, again the same medicine, glycomet. Side effects. Common side effects are, number one, many patients are tolerating these medicines. Some may get nausea, diarrhea, loose motions, and abdominal discomfort, which often subside with continued use. That means first week when you are prescribing glycomet, the patient may say, doctor, there is problem that I am getting some loose motion, I am getting vomiting sensation. Just ask the patient, wait and watch. After 15 days, after 3 weeks, if it is continued, then you can change the drug. But most of the patients, this particular side effect gradually leaves. That means it is stopped. Long-term use of glycomet can lead to vitamin B12 deficiency. Try to understand. This is very important. So glycomet always give B-plex 4 tablet. Glycomet for diabetes and B-plex 4 too. Write down. B-plex 4. Glycomet plus B-plex 4. Or any bigonide, you always prescribe B12 supplement. Now, a rare but serious side effect is lactic acidosis. For example, if any patient is having kidney problem or already liver problem, chronic renal failure, acute renal failure, nephrotic syndrome, urinary tract infections, pyelonephritis, All I am talking about kidney problems. Here, hepatitis B, then liver damage because of the liver cirrhosis, fatty liver, liver cancer, then be careful while using glycomet. What you can do? You can do every month renal function test, urea and creatinine, and liver function test. You can do after every 2 or 3 months and check whether there is any problem. But basically, you must try to avoid these drugs in the kidney and liver diseases. Now, second, sulfonylurea, the famous drug. 90% diabetic patients are on Dionil. Very popular. Dionil, very popular. Sulfonylurea, the example is Dionil. Okay. This is sulfonylurea group stimulates the insulin secretion from beta cells of pancreas by binding to ATP sensitive potassium channels. You can forget this word because you are not learning pharmacology. You can just remember this is stimulating insulin, centrally acting, beta cells of pancreas. Previously, what we say, they are acting on the receptors, that bigonides. Now these are acting on the directly on pancreas. Try to understand. Now here I would like to add one thing. Okay, that we will discuss in the second lecture. Anyways, but they are acting on the insulin beta cells. Okay, the most popular names are available is Glipizide. This is also popular. Glipizide is a generic name, and Amaryl is a brand name. Generic name, brand name. Generic name, brand name. All these are popular. Glipizide, popular. Glipizide, generic name. And Dimacron, brand name. Very popular. Amaryl popular, Dimacron popular, and Dionil is popular. Then Glipizide is also popular. Glipizide, that is glucotrol. Glucotrol. That means glucose controlling. So glucotrol. This is there are different names, you remember this Glipizide. So glimepiride, gliclazide, glipizide, and glyburide are all sulfonylureas. I repeat, generic names you must remember: glimepiride, gliclazide, glipizide, glyburide are all sulfonylurea stimulating insulin, stimulating beta cells of pancreas. Dionil. Doses vary depending on the specific drugs. For example, glimepiride typically starts at 1 milligram once daily and you can increase up to 8 milligram. Then there is a gliclazide MR. Usually starts with the 30 milligram once in a day and can increase up to 120 milligram. I request all of you, please make the tabular form. This is my homework for you. You can make the table and you can send me to the WhatsApp on 9226810630. Because if you made a table, then it is very easy to remember. First column, the name of the generic name, then the brand name, the minimum dose and the maximum dose. I repeat, how you should make the table. Title is OHA, oral hypoglycemic agent. In the first column, you write down the name of the medicine. In the second column, you write down the minimum dose, then the maximum dose, how it is action, and the side effects. So big table you can prepare. Okay. So they are usually taken once or twice daily before meals. This is Dionil. Side effects. The main side effect is hypoglycemia, and this is fatal. Huh? Try to understand. Diabetes has a two complication. One is hyperglycemia. Second is hypoglycemia. When the blood sugar goes below 60 mg per 100 ml, you can check all the time glucose by glucometer. You always ask or request the patient minimum, what you can say, they can have the instrument, that is glucometer, at their home, and they should learn how to check the blood sugar of their own. That is very essential, because whenever you start some medicines, better at least after 2 days to begin with, they must check their blood sugar. Then second side effect is weight gain. So these sulfonylureas cannot be given to the patient, what you can say, the obese patient, because that will be problematic. Other potential side effects include GIT, gastrointestinal tract upset, that means nausea, vomiting, loose motion, and some patients may get skin rash. Okay, next. Now we are talking about DPP4 inhibitors, that is gliptines. Huh? DPP4 inhibitors, that is gliptines. Now, this is an enzyme. What this enzyme is doing, breaks down hormones like GLP-1. So, this hormone is break by the enzyme GLP-1. That what is happening? That this leads to the increased levels of the GLP-1. This hormone is increased, GLP-1, and that will stimulate the insulin release, and that will reduce the glucagon secretion, a glucose dependent manner. So I think this is the indirect action. First, they are acting, these gliptines are acting on particular enzyme. This enzyme, this DPP4 is a enzyme, and they are stopping the action of this DPP4, okay, which breaks down the, because if this enzyme is working, this will damage this hormone. But this hormone GLP-1 is very much essential. GLP-1 hormone is essential. I repeat, these gliptines are acting on DPP4 enzyme, and they are inhibitors. They are stopping the action of DPP4. And what DPP4 usually do? They try to destroy this hormone, GLP-1. But we require this GLP-1 because GLP-1 is stimulating insulin. And we need the insulin. For the diabetic patient, we need the insulin. So we want to stop the action of this DPP4 enzyme. I hope these 3 points are there. DPP4 enzyme is there. It is destroying GLP-1 hormone. We don't want, because GLP-1 hormone is good because it is stimulating insulin. Okay. Now there are different, these gliptines is a generic name. What the market available drugs are, for example, sitagliptin. Sitagliptin is again type of the gliptines, and Istavel is the name of the brand name. Then there is a vildagliptin. The market name is Zomelis. Then there is a linagliptin. Then Tragental is a name of the drug. Then there is a saxagliptin. The Onigliza is a name. But my dear friends, I will say you that gliptines are consultant. They are mainly using these gliptines. General practitioner is not using much of the times of gliptines. This is a consultant type of the practice. Now, we are talking about gliptines, typically once daily. For example, sitagliptin is usually 100 milligram once in a day. Then linagliptin is 5 milligram once in a day. Then vildagliptin is 50 milligram once or twice in a day. Dose adjustments may be needed in patients with kidney problem for some gliptines. So remember, side effect, you make a table. I request all the viewers, all my subscribers to make a table of your own. This is like a homework for students. Side effects are generally well tolerated. Common side effects are usually mild. For example, nasopharyngitis. So there will be like a cold or cough symptoms. Sore throat will be there. Sometimes little bit headache should be there. Why you must remember the side effects? Because whenever you are prescribing to the medicines and the patient comes back to you, you should not get shocked. Then you should say, okay, I will take care of, I will reduce the dose. Don't worry, it will automatically go. There is a low risk of hypoglycemia when used alone, but a higher risk when combined with sulfonylurea. Because many times we have to give 2 types of the tablet, then risk is increased. Okay, let us move further. SGLT2 inhibitors. SGLT2 inhibitor. Now, what is that SGLT2? This is a protein in the kidney. This is a type of the protein in the kidney. And this is leading to the increased excretion of glucose in the urine. So we don't want the urine, glucose in the urine. We don't want glucose in the urine. Glycosuria, we don't want. Patient is getting problem with the glucose in the urine, and we want to stop that glucose in the urine. How does it can happen? That protein will be, the action of the protein will be stopped. SGLT2 is a protein in the kidney. SGLT2 is a protein in the kidney. These particular glyphosins or glyphosins, that will inhibit the action of this protein, and naturally blood glucose will come down and urine glucose will not be there. Okay. Now, commonly used this particular SGLT2 inhibitors are whatever the Indian brands are available. For example, dapagliflozin, dapagliflozin. The name is Forza or Oxra. Again, why I am not pronouncing very well? Because in general medical practice, we don't go for these glyphosins. This is again consultant. Okay. Then different, you need not to remember all these names in the examination. Only you remember the head title, then give one or two examples like Oxra, or you can say the, for example, Invokana. I am pronouncing only simple names. Okay. Then here, Stiglatro. That is, this is glyphosins. Again, consultants, what you can say, the influence is there. General practitioner is not using this medicine. Now, SGLT2 inhibitors taken once daily. For example, dapagliflozin is usually 10 milligram once in a day, and empagliflozin is 10 milligram or 25 milligram once daily. If you can make the table, then only you will remember. Slides are not very much, slides are for explanation for Dr. Deshpande, but for the students, they must immediately prepare the table, and please, you can make the photo and also upload on the comments, or you can send me on the WhatsApp. Now, what is the side effect? Increased risk of genital fungal infection. Yeast means fungal. You can get the fungal infection to the, what you can say, the urethra, penis, or the vagina, urinary, the genital infections. Yeast means fungal infection. And also there is a chance of urinary tract infection due to increased glucose in the urine. The patient is also passing in glycosuria is there, so naturally infections spread. But these infections can be controlled by these particular medicines. Other potential side effects include increased urination, dehydration, and a rare risk of diabetic ketoacidosis. Diabetic ketoacidosis means hyperglycemia. These drugs also shown cardiovascular and renal benefits in some patients. So consultant, cardiologist, or the nephrologist, these patients are using these glyphosins because they are beneficial. Diabetes plus heart problem, diabetes plus kidney problem, then the doctors are using, consultants are using glyphosins. Next, glitazones. I think glitazones is more common in the general practitioner. Mechanism of action: increase the insulin sensitivity in peripheral tissue, that is muscles and fat. Okay, you forget about the next sentence. You forget about that. Only they are acting on the what you can say receptors. They are increasing the activity of receptors. They are making more number of receptors. Quality of the receptor is increased because of these glitazones. They also reduce the hepatic glucose production to some extent. They also reduce hepatic conversion from glycogen to glucose is not taking place. Okay. Now, next we are talking about rosiglitazone is restricted in some countries due to the cardiovascular problem, but may still have limited use based on specific clinical scenarios. That means pioglitazone and rosiglitazone. Please remember these names. These are very common nowadays. These are recent drugs. For example, in the antibiotic, first generation, second generation, third generation. Similarly, here this is the third generation medicine, pioglitazone, rosiglitazone. Remember, common in GP. Pioglitazone, rosiglitazone. Pioglitazone, rosiglitazone. Don't forget. These are the glitazones. They are increasing the sensitivity of the periphery, not on the pancreas. They are acting on the receptors. Now, pioglitazone is usually started 15 milligram to 30 milligram once in a day and can be increased to 45 milligram once daily. Please, please, please make the table immediately. After completing lecture, you prepare the best table because you have to write only 9 or 8 drugs on the left side. Give the serial number. Immediately you can send, make the table, take the photo and send it to me. So in the afternoon lecture, we can discuss with that table also. So very simple table. First serial number, then name of the drug, then you can generic and brand name. Brand name in the bracket, generic name on the up. Then next will be the minimum dose, maximum dose, side effects and action. Last will be the action because we are not learning pharmacology. We are learning the medicine. So action of the drug should be the last column. Okay. This pioglitazone is also can cause the weight gain. So very careful when the patient is obese. It can also cause the edema, fluid retention, and increased risk of heart failure, that is congestive cardiac failure, CCF. Okay, there is also an increased risk of bone fractures. So in the old people, when there is osteoporosis, when there is osteopenia, don't use. Osteoarthritis patient, don't use because this is giving the bone fracture side effect, particularly in the women. So after menopause, when estrogen is less, don't use because the ladies will start getting, when they will fall down, a lady of 60 years in the bathroom, she will get immediate fracture. Then liver function should be monitored. Every after 1 month, 2 months, 3 months, you must do liver function test. And you know, there is a 10 to 12 hours fasting is must before doing liver function test or even lipid profile. Fasting is very much essential. Try to understand. Fasting is very much essential. Last night you eat dinner 8 p.m. In the next morning you go to the laboratory at 8 early in the morning or 8 a.m. or 10 a.m. So 10 to 12 hour fasting is very essential for liver function test. What are the liver function test? Bilirubin, SGOT, SGPT, and alkaline phosphatase. These are all liver function tests which are included in that particular test. Next is a meglitinides, that is glinides. Similar to the sulfonylurea, they stimulate insulin secretion from the pancreas but have a shorter duration of action. They are taken before meal to control post-meal glucose spike. Many patients, you know, when the patient is diabetic, what we do? Routine examination, do you remember? First is a fasting blood glucose, fasting blood sugar, FBS. And second is postprandial blood sugar, PP. PP, postprandial. PP, postprandial blood sugar. Usually, fasting blood sugar, you go to the laboratory without taking breakfast, without taking milk with sugar, without taking tea, without taking coffee. But, patient can drink water. Please try to understand. Patient can drink the water. Fasting, water is allowed. Okay. And then, for example, the patient has finished lunch at 1 p.m. 1 p.m. Then exactly after 1.45 minutes, please remember 1.45 minutes. That means the patient's blood should be taken at 2.45 p.m. Patient has completed the lunch at 1 p.m. Completed the lunch. Try to understand, not starting the lunch. Completed lunch at 1 and take the blood at 2:45 p.m. Please write down these notes. These are very practical hints. Okay. Then whenever you give the blood, better way you can give also urine sample. So simultaneously we can see the two things, whether there is a glucose in the urine and whether there is a sugar in the blood. Okay. Now, These meglitinides, the name is ripaglinide, very costly drugs. Third, fourth generation drug, ripaglinide, very common with the consultant, ripaglinide. Then there is a natiglinide, ripaglinide, natiglinide. These are the main drugs from this particular class. These are called as the glinides. Ripaglinide is typically taken 2 to 4 times in a day because they are short acting. Try to understand, when short acting, we have to give frequently, 15 to 13 minutes before meals, with doses ranging from 0.5 to 4 milligram per meal. Maximum dose 16 milligram total whole day. For example, 4 milligram tablet can be taken maximum 4 times in a day. This is very small tablet, but this natiglinide is usually 60 to 120 milligram taken before meal. But here there is a risk, hypoglycemia. So if the patient is not sure whether he is taking the lunch or dinner, then don't give this tablet, please, my dear friends. I have seen the patients, old people, 65 or 70-year people. I prescribe these medicines. What is ripaglinide? He has taken the medicine and all of a sudden he said, no, I am having gas in the stomach. I will not eat now. I will not eat. He has already taken the medicine. We cannot take the medicine from the stomach. No? He has already taken. It is entered into the blood and he is not eating. The patient is refusing the lunch because he is having some problem in the stomach, some problem in the abdomen. He has started the pain. So don't do like that. When you are sure, when his meal is ready on the table, then only ask him to take the medicine. Better not to take, but taking medicine and not eating is a very risk. Hypoglycemia, the patient can die when the blood sugar goes down 60 milligram per 100 ml. It is immediately you can check on the glucometer. And you must remember the most important symptoms of hypoglycemia. Number 1, patient becomes drowsy and unconscious, irrelevant talk, and most important, severe perspiration. Lot of sweating from head to the foot. This much sweating. And sweating in the old people can occur only because of 2 things. One is a diabetes, hypoglycemia, and second is a heart attack. So don't forget these my things, very important. Okay, this is less than with longer acting sulfonylurea, but sulfonylurea is always having the maximum danger of hypoglycemia. Here weight gain can also occur, so be careful with the obese people. 7th drug is alpha glucosidase inhibitor. Whenever there is ASE, AS is an enzyme. So they are also inhibiting one particular enzyme in the small intestine. This enzyme do the breakdown of the complex carbohydrates into glucose and thus slowing down the absorption of glucose after a meal and reducing the postprandial hyperglycemia. So this is the important drug, very important drug. Orally, when you have the oral in the examination, they will ask you which medicine can control PP, blood sugar, PP. Some patient fasting is always normal, but PP is high. So for these patients, acarbose is the best medicine. Acarbose is the best medicine. Don't forget this name, very popular. Acarbose, this is generic name, this is a brand name. Glucobe. Only remember acarbose, glucobe. Acarbose, glucobe, PP sugar. Acarbose, glucobe, postprandial blood sugar control. Acarbose, glucobe, postprandial blood sugar control. Are you getting my point? So this is the best medicine to control PP because in the intestine, this enzyme is doing the breakdown of carbohydrate. So from carbohydrate, glucose is formed. This is a simple our physiology. So this activity, conversion of carbohydrate to glucose is stopped because this medicine, this acarbose is stopping the action of inhibit, means stopping the action of this enzyme. Stopping the action of enzyme in the intestines. Okay. Now, acarbose usually taken 3 times in a day with the first dose bite of each main meal. Acarbose typically starts at 25 milligram 3 times daily and can be increased maximum to 100 milligram 3 times in a day. Voglibos usually starts 0.2 milligram 3 times in a day and can be increased to 0.3 milligram 3 times in a day. My dear friends, make a table immediately. Common side effects are GI upset, like flatulence, gas in the stomach, bloating, diarrhea, loose motions, due to the undigested carbohydrates reaching to the large intestine. Okay. Now, oral GLP receptor agonist. Agonist means same action. These are newer, very fresh oral formulations that mimic means similar, the action of incretin hormone, stimulating insulin release, suppressing glucagon secretion, slowing the gastric emptying, and promoting the satiety. Very, very difficult to understand all these things. I request all of you, you just tell that GLP-1 receptor agonists are basically suppress the glucagon. Glucagon is a hormone which converts glycogen to glucose in the liver. So liver action has stopped, and also the receptors are sensitized more potently, and they are acting good. They are receiving the insulin, and that's why insulin is helping. What is the role of insulin? Taking the blood sugar from the blood into the cell. What is the action of insulin? Taking the sugar from blood to the cells. Now, what is the example? Semaglutide. Semaglutide is an example of this GLP-1 receptor. They are acting on the receptors. Okay. So this is a typically started at 3 milligram once in a daily for 1 month, then increase to maintenance dose of 7 milligram or 14 milligram once in a day. It should be taken on the empty stomach within a sip of water at least 30 minutes before the first food or drink of the day. Common side effects: GI tract problem, nausea, vomiting, diarrhea. This is very easy to remember, which are usually mild to moderate and transient. I think most probably the slides are completed, and okay. The small remarks are there. Obese diabetic patient, which medicine you can use? First line is a metformin, is generally the preferred first line agent due to the efficacy, low risk of hypoglycemia when used alone, potential for modest weight loss or weight neutrality, and cardiovascular benefits shown in some studies. So metformin is for obese patient, metformin is for obese with cardiac problem, and metformin is having what you can say the benefit of getting weight loss. Okay, next. Second line and beyond. There are the different steps, but I think we can go fast because in the second lecture I am going more specific for this type of explanation. Then there is the SGL2 inhibitors, for example, dapagliflozin, or I have used the different semaglutides are there. They are there for the weight loss benefits, and again, heart and the kidney protection. Then there is a DPP4 inhibitors are weight neutral. That means they will not cause any loss or any gain in the weight. So this is also a good option. Okay. Then there is another group of the drugs, that is thiazolidinons, can lead to the weight gain and fluid retention. So they can use very cautiously. Sulfonylureas and meglitinides can cause the weight gain. Okay. Lean. Now there is a, when there a patient is having the low weight patient, then there is a metformin can still be used, but its a gastrointestinal side effects might be less tolerated in lean patients. Okay. For the lean patients, other options are sulfonylurea and meglitinides can be effective in stimulating insulin secretion in lean patients with impaired beta cell functions. DPP4 inhibitors can also a good option due to their low risk of hypoglycemia and weight neutrality. SGLT2 inhibitors can be used, but their weight loss effect might not be desirable because they are already having less weight. Okay, they need adequate renal function. Then thiazolidinons side effects profile of weight gain and fluid retention needs careful consideration. Alpha glucosidase inhibitors can be used to target postprandial hyperglycemia without causing weight gain. Last 3-4 slides, you can just relax because in the second lecture, we will talk much more, what you can say, the simple language. Okay, this is little bit complicated language. Now, initiation of treatment. Determine first whether the patient is underweight or normal weight or overweight. Accordingly, you have to choose the medicine. If the patient is underweight or normal weight, the patient is put on 1/4 of the maximum effective dose of sulfonylurea, that is dionyl, whose maximum effect dose is 20 milligram, is given. Then 2.5 milligram BD before food, that is 5 milligram daily. Then if blood sugar levels are still high after 3 weeks, the dose is increased to half the maximum effective dose, that is 10 milligram daily. A further dose increase is unlikely to be useful. So these are the steps that must be followed. You have to write down. Now, first table you have made about the information about the medicines. Now you can write down the different steps, how you can go for treating this particular diabetic patient. First, you must decide, always take the weight of the patient, and height weight chart. You should be put it on your wall of the dispensary or beneath the glass of your table. And then you can select the drugs. For example, if the patient is underweight, always sulfonylurea. I will repeat 3 times. Underweight, normal weight, sulfonylurea. Underweight, normal weight, sulfonylurea. Underweight, normal weight, sulfonylurea dionyl. Sulfonylurea dionyl. Overweight, metformin. Overweight, metformin. Okay. Next. Even a change to another sulfonylurea may not help. This is then called as a primary failure, which is seen in 20% of the patient. Many of the patients who initially respond to the sulfonylurea do not do after 10 years of this medicine. This is called as a secondary failure. This is maybe due to the progressive deterioration of the beta cell function, because sulfonylurea is acting on pancreas, on the beta cells. In such cases, metformin or glitazone or both, these combinations are available in the market, sticking to the same principle of starting with a low dose and gradually increase up to maximum dose within the 3 weeks. If the event that fasting blood sugar is normal but PP is high, then only option is acarbose. Acarbose may be added. If all the combinations fail, then there is no option but to start insulin. Now, if the patient is overweight, I think last between 4 slides are not very useful, but last 4 slides are very useful. If patient is overweight, metformin is the drug of choice because it is causing the weight loss. This is beneficial if in this patient. Half to 1 tablet of 500 milligram glyphosate. Remember this name. Sulfonylurea dionyl. Here glyphosate BD is recommended after or during the food to prevent the gastritis. Never give before the food, always after the food, because it can cause the gastritis. If blood sugar level values are still high after 3 weeks, a sulfonylurea is added either alone or with pioglitazones. Again, if these combinations fail, there is no option but to take the insulin. If the patient becomes euglycemic with any of the above regimen, the corrected dose is continued and blood sugar levels are monitored every after 3 months along with this particular test. Glycosylated hemoglobin is very important. If these are satisfactory, that means fasting blood sugar is less than 100 milligram, postprandial blood sugar less than 130, and glycosylated hemoglobin is less than 6%, an attempt is made to reduce the dose periodically. This is necessary because with the improvement of the glycemic control and decrease in weight, islet cell function improves and patient may get repeated hypoglycemic attack. Now, maintenance treatment. If in patients controlled on a small dose of OHA, the drug can be withdrawn abruptly, oral hypoglycemic agent. If a patient on a large dose of oral hypoglycemic agent, the dose should be gradually tapered off. Remember this. Similarly, in patients with well controlled with less than 20 units of insulin, insulin can be stopped abruptly and the patient put on oral hypoglycemic agents. However, if the dose of insulin is more than 20 units, the dose should be progressively, step by step, used reduce the dose of insulin. Okay. Now, general principles for starting and combining oral hypoglycemic drugs. This is very important. Lifestyle modification first. Diet and exercise are the cornerstone of type 2 diabetes management and should be emphasized for all patients. That means if somebody is saying that I am taking tablet, no need to control diet, no need to exercise, that is wrong. Start low, go slow. Initiate the oral agents at the lowest effective dose to minimize the side effects and gradually titrate upwards based on hypoglycemic response and tolerability. Third, individualized therapy. Choose the drug or drugs based on the patient's specific needs. Then, what you can say, the preferences and these all the other things. Fourth one is a monitor regularly. Frequent monitoring of blood glucose level, that is by glucometer, self monitoring, and HbA1c every 3 months is essential to assess treatment efficacy and adjust therapy as needed. Next, consider combination therapy. Many patients will require more than one oral medicine to achieve and maintain target glucose levels. Combining drugs with different mechanism of action can be more effective. Be aware of side effects. Educate the patients about potential side effects and how to manage them. Monitor for adverse effects and adjust the therapy if necessary. Now, consider cost and availability. The cost of the medications can be significant factor, especially in India. Generic versions are often more affordable. Regular review. Diabetes management is a dynamic. Regularly review the patient's treatment plan and adjust is based on the changes in their condition, lifestyle, and glycemic control. My dear friend, this is all for today's lecture about OHA part 1. OHA part 2 will be seen in the next video. If anybody of you suffering from any physical or psychological problem, they can WhatsApp for paid online consultation. Next, this is the educational video. Naturally, disclaimer, whenever necessary, you must take the family physician advice. I request all of you to like this video, share this video, and don't forget to subscribe my YouTube channel. I wish you all the best. Take care and see you in the next video. Thank you.